like to present a 54-year-old woman with newly diagnosed advanced epithelial ovarian cancer. She represents sort of the typical scenario. 54 years old, comes to her gynecologist, thinks that she has some symptoms in her pelvis, urinary frequency, a little early satiety, kind of bloated, and it's been gradual over the last handful of months. So she goes to see her gynecologist. Her gynecologist does a physical examination and fills a mass. Notes her past medical history of obesity, pre-diabetes, so diabetes that's controlled with diet, and also some controlled single medication hypertension. Does a CAT scan, confirms that there is 11-centimeter pelvic mass. Interestingly, there is some ascites and some carcinomatosis on the CAT scan, and as is routine, does a CA-125, which is elevated at 785. So what's the right step? Well, the right step is referral to a gynecologic oncologist. She's evaluated by the gynecologic oncologist, and the gynecologic oncologist recommends that she have a midline laparotomy with a surgery, planning a hysterectomy with the preemptive diagnosis of ovarian cancer, and ultimately likely a debulking surgery, maybe even a bowel resection. So she undergoes an exploratory laparotomy, total abdominal hysterectomy, bilateral salpingo-oophorectomy, omentectomy, and debulking, and indeed, the pathology shows a high-grade serous ovarian cancer. Interestingly, the entire debulking was not successful. There was just over a centimeter of residual disease, what we would call large volume residual disease. And the reason that it was not completely resected is because it involved the porta hepatis right there next to the gallbladder, next to the portal vein, peritoneal disease, if you will. And so she had large volume residual disease and is sent for the evaluation of adjuvant chemotherapy. At that time, she undergoes genetic counseling and has germline BRCA testing and is found to be negative for deleterious or suspected deleterious BRCA1 or BRCA2 mutations. So the patient under consideration, again, is 54 years old, pre-diabetic, hypertensive, mildly obese, and is recovering from a midline laparotomy debulking surgery. First thing we do is we look at histologic subtype. Her histology is a high-grade serous ovarian cancer. That represents about 85% of newly diagnosed cases. Second, we look at the molecular signature. She does not have a germline BRCA mutation, and I could just add that she should have had somatic BRCA testing, and she's also somatic BRCA negative. And then finally, we look at the residual disease, and she has large volume residual disease, just over a centimeter. The consideration now is to consider adjuvant therapy. But first, I want to comment that the most difficult decision that we make when confronted with a woman who is suspected to have an advanced ovarian cancer is whether to begin with chemotherapy or to begin with an operation. When we begin with chemotherapy, that's called neoadjuvant chemotherapy. Then the surgery is interdigitated between the third and the fourth doses, typically with the plan ultimately of either 6 continuous doses of chemotherapy or 3 surgery and 3. So how do you figure out whether or not a patient should have neoadjuvant chemotherapy or primary debulking? And again, that's the hardest decision that we make. In this particular patient, she had large volume residual disease, and so one could argue that she should have had neoadjuvant. It's a tough decision. More and more, the surgeon is looking in with a laparoscope to get an assessment. This particular patient did not have a laparoscopic assessment. The decision was made to go directly to debulking surgery. You really can't be critical, though, that the surgeon tried, and it's understood that occasionally there is unresectable residual disease.